Ready.
All right, started, and here is your question. Right. Right. So if you have read and understood, considering its surgical anatomy station, kindly tell me what are you looking at? Sorry.
I'm looking
yes,
at
now. Identify the structures from A to S, please. What is A?
A is the biceps brachii.
Okay. B.
B is median nerve.
C.
C is the medial cutaneous nerve of forearm. D is the
just imagine it's a dissection and these structures are exposed and you're trying to identify them. Okay, what is E, please?
E is axillary nerve.
F, please.
F is the radial nerve.
Okay, what is all this that you're looking at?
I'm looking at the brachial plexus.
Okay, very good. Can you please tell me what are the parts of brachial plexus?
It has mainly 5 parts:
all
the
right,
roots,
good.
trunks, division, cords, and the branches, terminal branches.
Yes. Can you tell me how many branches there are which arise from the roots?
From the roots, we have dorsoscapular,
yes,
nerve to subclavius. Sorry, dorsoscapular and long thoracic nerve, and the contribution to the phrenic nerve from C5.
Very good. All right. Tell me if there are any nerves which comes out from division.
No.
Oh, good. If there are any nerves which comes out from trunks.
Trunk, yes, we have from the upper trunk we have two branches:
very
the
good.
suprascapular nerve and the nerve to subclavius.
All right, good. And what are the terminal branches? How the cords are formed? First, tell me how the cords are formed, and then what are the terminal branches, please?
There are 3 cords: the lateral cord, posterior cord, and medial cord.
Yes.
They are formed by the anterior and posterior divisions of the 3 trunks.
Okay.
The lateral cord is formed by anterior divisions of the two anterior divisions of the upper and middle cord. Sorry, middle trunk, and posterior cord is formed by the 3 posterior divisions of the upper, middle, and lower. Yes, 3 trunks, and middle cord is formed by the anterior division of the inferior trunk.
Okay. What are the terminal branches of the nerves?
The main terminal branches from lateral to middle, we have musculocutaneous nerves, the axillary nerve, radial nerve, median, and ulnar nerve.
Okay, good. Can you tell me what are the differences between Erb's paralysis and Klundvik's paralysis?
The Erb's paralysis, it involves the damage of or palsy to the upper nerve root.
Yes.
Upper trunk, and
involving which nerve roots?
C5 and C6.
All right.
And the Klumpkis, it involves the injury to inferior trunk involving C8 and T1 nerve roots.
What are the motor area which are affected in both?
In case of paralysis, the abductors of the arm is affected, and also the flexion is affected. The supination flexion of the elbow is affected, and also the extension of the wrist is affected. Therefore, the arm is adducted, extended, pronated, and flexion at the wrist.
In case of paralysis, what about Klumpkis?
Yes. In case of Klumpkis, the main deformity is the claw of the hand, where the intrinsic muscles of the hand is paralyzed.
Yes. And there is a flexion of
the PIP joint and hyperextension of the MCP joint.
All right, good. What are the sensory loss in both the conditions?
In case of Erb's paralysis, the loss of sensation is on the radial side of the arm and forearm, and in case of Klumpkis, on the medial side of the ulnar side of the forearm, arm, and the hand.
Good. How the injury takes place when it comes to Erb's paralysis?
Usually,
what is the mode of injury?
Paralysis, it is because of the hyperextension of the neck on the opposite side. Usually because of trauma or fall on the shoulder.
All right.
And in case of shoulder dystocia during birth.
Yes. And
also sometimes due to anesthesia also.
All right.
And in case of Klumpkis paralysis, it is because of the hyperabduction of the arm.
Yes.
Like from while breaking from a fall.
Yes.
Or
reaching
during birth
out
injury.
for something. Yes. While falling.
Yes.
Very good. Okay. What are the common terminologies which are used as a slang for these two conditions?
In case of Erb's, we use as waiter stiff hand, policeman stiff hand, or porter stiff hand.
Yes.
In case of Klumpkis, it's called the ulnar hand claw hand deformity.
Yes, there is also something called bishop's hand, if you know what that is. Maybe
bishops or hands of benediction.
A hand of benediction, yes.
That is in case of injury to medial nerve in the proximal part.
Yes. Okay. Can you please tell me if there is injury to the if there is injury in the axilla, which nerves or which structures will get injured?
In the axilla, usually the cords are related to the axillary artery.
Yes.
And therefore,
what is exact
terminal branches from the cords would be affected.
Yes. Okay. So, what is exact surface marking of the brachial plexus in axilla? They are located behind what?
Of the brachial plexus?
Yes, please.
Yes, the roots, they exit from the intervertebral foramina lies between the scalenus anterior and medius. The trunk, it lies at the base of the posterior triangle in the neck and behind the third part of subclavian artery.
Yes.
Division, it lies behind the middle third of the clavicle.
Yes.
And cords are related to the second part of axillary artery.
Good. There is a term most often used, prefixed and postfixed brachial plexus. What do you understand by that?
Prefixed means when the C4 joins the C5.
Yes.
And postfixed means when the T2 joins the T1.
Very good. All right. Thank you. Yes. Sorry. Is should not be there.
Ma'am, is this depression? Okay.
Yes, depression
Is it depression
like,
or anxiety?
it's pre of confusion.
Anxiety.
Yeah, pre of
This one is
confusion.
anxiety.
Yes.
Yeah, this is anxiety.
This is anxiety, ma'am.
Yes, this is anxiety. I don't have a depression one. It's like combined.
Okay, okay, ma'am.
History, if you look, it's the same. But
Okay.
under depression, even the same history is given.
Okay, ma'am.
Basic definition of depression is when there is a low mood for more than 15 days. So they cannot have this pre of, they cannot find pre of all of a sudden depression, but it's anxiety or confusion.
Okay.
Yes, please continue. If you think, if you have read and understood and considering it, history consideration, kindly begin.
I'm ready.
Okay. Would you mind if I asked you some questions to test your memory?
First, you came inside, you introduced yourself, you washed your hands, and then you confirmed the identity of the patient. Then please.
Okay.
Asking name and age.
I'm Dr. Ilmun Kabi, one of the exam candidate. Before beginning the examinations and talking to the patients, I will wash my hand and confirm the patient's name by checking the wristband. As the patient is confused, maybe she didn't admit her name. So I start my examinations by asking her
No,
name.
it's history. It's history, Dr. Emo. It's
It's
history.
history.
Yes. Yes, yes. So would
So
you
you'll
mind
come
if
in
I
and
ask
we'll
you
ask,
some
how are you feeling
questions?
now? Yes.
Ma'am, I will take the history of depression or confusions.
Confusion doesn't matter. It's the same history.
Okay. Okay. So would you mind if I ask you some questions to test your memory, Miss?
You don't know my name yet. I am Mr. Smith, doctor. You didn't ask me of my name, doctor.
I think I asked. Okay.
Yeah.
Sorry. I have
It's
to.
a lady, so Samantha or something.
Okay, Mrs.
Or Mrs.
Yes.
Smith.
Mrs. Smith.
Yes.
Mrs.
Yes,
Smith.
Mrs. Smith. Okay. Mrs. Smith, do you know where we were right now?
Yes, I do. In the hospital, doctor.
Okay. Thank you. So can you tell me what is my job?
I think you are the you are the dietitian or something, dietitian.
Okay. Can you just help me to tell the name of the current Prime Minister of London, of England?
Prime
Yes.
Minister of England. Doctor, I can't remember now. I can't remember.
Okay, it's okay, no problem. Can you tell me the name of the Queen of England?
Is it not Margaret? Margaret.
Okay.
Margaret.
Okay, I'm telling you an address. At the end of our discussions, I will again ask you about this address. This is 24 West London, okay?
Yes.
Okay, 24 West London. So, Mrs. Smith, can you tell me what is the year it is?
Yeah, this is 2021, doctor.
Okay, and what is the time of the day right now?
Doctor, this is morning hours, doctor.
Morning. Okay.
Morning hours.
Can you tell me the date of your date of birth?
Doctor, my date of birth. My date of birth, doctor.
It's okay.
Can't-
It's okay.
Yeah, thank you.
No problem. Just tell me, how old are you?
Doctor, I'm 37, doctor. No, 38, doctor. I'm 37. I'm 36, 38,
Okay.
doctor. Yes, doctor.
Okay, no problem. So, can you tell me, when did World War happen?
World War is in 2017, doctor. 20,
Oh,
yes, 2017.
okay. Can you count backwards, like from 20 to 1, like 20, 19, 18, like that? Can you count backwards
Okay,
for me?
let me try. Okay, let me try, doctor. 20,
Hmm.
19,
Yes.
18,
Yes.
15,
Okay. Okay. It's
14.
fine.
Okay. All right, thank
Okay,
you.
fine. So I told you to remember the address. Can you tell me now?
27 East London.
Okay. Thank you. So after assessing thank you, Mrs. Smith. I will get back to you as soon as possible. So as her scores, MTS scores is less than 6, so the patient is suffering from confusions. So to complete my assessment of the patient, I will do mini mental state examinations.
Okay.
Ma'am, should I?
Doctor, I came here for surgery, doctor.
Yes.
Yes, I don't know. I don't know. What do you want to do for me, doctor? I'm really scared. I'm not sure I'm ready for this surgery, doctor.
Okay, listen, the operation is not so
Okay.
urgent.
Can you
Before,
present
during,
this now?
okay. After assessing the patient's AMC score, the score is less than 6.
Yes.
The patient is 36 years old. We came here for elective cholecystectomy. The patient couldn't remember her age, date of birth, and the day, but he can remember my job and what we are right now. So after assessing this, the scores is less than 6. So I will go for the MMC score.
Yes.
And after that, I will assess whether the patient is fit for a cholecystectomy or not.
All right. Do you think patient is not fit for the operation, for the surgery? Or should the patient go ahead as planned?
The patient, no, not fit for giving a consent, as she cannot retain information.
Yes.
And cannot make an informed decision.
Good. So what are the differential diagnoses that you'll consider?
Maybe the patient is suffering from electrolyte imbalance, or hypoglycemia, or hypotension, or because of her age, maybe is suffering from any kind of CNS lesions, or
Yes. What
maybe
are the
some drug
management?
toxicity.
What are the management options that you will consider for her?
Okay. At first, I will go to observe the patient by seeing his vitals, like pulse, blood pressure, temperature, respiratory rate, saturation. Then to exclude my differentials, I will do the CT scan of her head, then do some investigations like full blood count, urine routine microscope examination, liver function test, then thyroid function test as she is a female, then serum calcium level, and some vitamin B12 and folate and glucose. Besides these, I will do to see is there any infections present. I will do a blood cultures or chest X-ray.
And you'll send a request for medical registrar to have a look at the patient.
Yes.
Good. Right. Here is your question. Right. So if you have read and understood considering the critical care scenario, kindly tell me how would you manage this patient now?
Okay, ma'am. We manage the patient using the advanced trauma life support protocol.
Yes.
So we want to assess the patient airway. If patient is talking, because of the risks of additional injury that he has, if there's any swelling or anything that could make his airway to be obstructed, I want to remove them. Also, I will check that his breathing is fine, and then also I'll set and I'll secure 2 IV cannulas for him to then take investigation samples and then give him fluid. I will ensure that he's conscious.
How would you make sure how much fluid to be given to this patient?
Okay, I will use the Parkland's formula to calculate the fluid after assessing the percentage of area of body surface area involved in the bones, and then his weight times 4.
Okay. How would you calculate how much percentage of burn this patient has?
Yes, I'll use the Wiley's rule of 9 to calculate the amount of body surface area involved in the.
If this patient has burn on face, trunk, left arm, and both thighs, how much percentage of body has been burned?
Okay, for the trunk is both anterior and posterior is 18%, that's 36. The left arm is
9%,
and then both thighs are also 18, so that's 36, 72 plus 9, 81. Then the face, maybe about 4-5%. So that's about more than about 85%.
All right. How would you make sure how would you confirm or make sure this is second-degree burns? In other words, patients with second-degree burns present with what sign and symptoms?
The burns, the part of the body involved, we have they will still be painful, sensitive, and then there may be erythematous, or there may be formation of blisters where that is involved.
Would there be formation of blisters? Would there be blisters?
No formation of blisters.
Yes, because if there is blisters, then this is first-degree burn, not second or third. All right. If you don't treat this patient, what are the fears or the complications that can result?
Yes. The patient can have shock.
What type of shock?
Acute renal failure.
What type of shock?
Hypovolemic shock.
Hypovolemic shock, please.
Hypovolemic shock.
Yes. Then
acute renal failure, respiratory failure can also occur. And then patients could also have sepsis from the burns.
Very good. Anything else?
Then death.
Yes, death. Before death, there could be coagulopathy, electrolyte.
Okay, coagulopathy. Yes. Then malnutrition also can occur, anemia.
All right. Okay. Can you please tell me if patient has ARDS as a result of burns, how would you know what are the characteristics, what are the signs and symptoms which patient will depict?
Okay, for each patient has ARDS, patients we have difficulty with breathing, we have shortness of difficulty with breathing.
What
then,
type of breathing?
May also be they have shortness of breath.
Okay, there'll be severe lung
Then they
injury,
also have
so
chest,
there'll be progressive refractive
chest,
hypoxemia, yes.
then chest pain also, they may have chest pain, then they'll be tachypneic.
All right, okay.
Also.
Right, can you tell me what is Berlin's criteria?
Okay, Berlin's criteria is used in for assessing ARDS. It has, if the injury occurs, it has like 3 criteria. If the injury occurs within 7 days, so when patient has ARDS within 7 days of acute insult to the patient, then when the PaO2 and FiO2 is less than 300 millimeter of mercury for in the patient, and then one has ruled out a fluid overload or cardiac problem as cause of the patient's present condition.
All right, then how do you think patient with ARDS should be managed?
Okay, for patients with ARDS, I will manage patients in ICU.
All
so
right.
Patients we have,
Yes, all right, then.
Patients will be intubated, adequate fluid, and the fluid intake will be restricted so as to prevent pulmonary edema.
Yes.
Then analgesics, and then patient will be nurse in prone condition. Then also be intubated and mechanical ventilation.
Would you give any antibiotic to the patient?
Yes, ma'am. I'll give antibiotics to prevent infection.
If patient does not respond to this management that you have done, what is the last effort that you will do, which can save the patient with ARDS?
Mechanical I will intubate patients and ventilate patients mechanically.
You did mechanical ventilations and everything, and patient has not responded. What is the last thing that you can try? Do you know what ECMO is?
I don't know, ma'am.
ECMO? What is ECMO?
I didn't get it, ma'am.
ECMO. I can write.
Okay, ECMO. Okay,
yes.
Is extracorporeal.
Yes.
Mechanical ventilation.
Is it mechanical?
Is extracorporeal. I can't remember, ma'am.
Yes, you learned this. Okay. Can
Yes.
you name certain complications which can result because of the presence of ARDS or untreated ARDS?
Okay, my patient can have acute renal failure, and respiratory failure can also occur, and then septicemia. Then patient can have disseminated intravascular coagulation.
Okay. What about nutritional status of the patient? How would that be affected?
Yes, the nutritional status of the patient will be affected. Patient will need more, because of the bones and then the ARDS, will need more energy intake, which will be
there'll be malnutrition, there'll be anemia, there'll be electrolyte deficiency.
Yes,
okay. Can you tell me the sequelae which take place that leads to ARDS? It is very important. Okay, what are the phases which are involved in it?
Okay, the phases are the exudative phase, then the proliferation, and then the fibrotic phase, ma'am.
Okay. So usually, what happens in these phases, please?
Usually there is acute alveolar injury, which leads to exudation of fluid into the alveolus, which then impairs the ventilation perfusion ratio of the lungs.
All right. Okay, a last question, please. How should the patient's nutrition be managed, these patients?
How should the patient be?
Nutritional status be managed?
Okay, the nutrition status will be calculated. The patient will have both maintenance nutrition, which will be calculated using 30 kilocal per kg, and then added extra one will be added, about 50 to 100% increase because of the bones that the patient has.
All right. Where would you manage this patient?
In the bones unit, ma.
All right. What are the criteria, or what is the criteria for admission to burns unit?
Okay, if for an adult, the patient has more than 15% body surface area involvement, and then if it's more than 10% in children, if patient has a major burns, affectation of the face, or presence of inhalational injury. Then if patient also has patient needs to have a sclerotomy or fasciotomy for presence of compartment syndrome.
Okay.
Ma.
Is there any difference for adults and children or elderly?
The difference
criteria?
Yes, I mentioned for children is usually 10% affectation of the body surface area.
And for elderly as well. How much?
For elderly is usually 15%.
All right, good. You know that this one. Good. Can you please read this image before we end?
Okay, this is the chest, a plain radiograph of the chest.
Yes, erect view.
Ma?
Erect view.
Yes, my erect view.
It
shows widespread opacity involving the long slits, both long slits, and then there is loss of costophrenic angle on the left.
Yes. Are these opacities?
Ma?
Are these opacities? You said opacities.
Yes, I think
you
so.
can have help.
Okay, somebody can. Okay, Kelly's line. Okay, yeah, Kelly's line, then the B line.
They're telling you.
I'll go and read it up. I know there are some lines, Kelly's line, B lines, and some other ones, but I'll read it up, man.
All right. Anyone else want to tell?
Hello, ma'am.
Yes, hello.
Yes,
Do
ma'am.
you want to discuss?
Okay, for the imaging.
Yes, please.
Yes, ma'am. They look like reticulonodular opacities and fluffy.
How do you feel the fluffiness while just looking at it? How you know
Yes,
it's fluffy? Fluffy is not the right word to read X-ray.
Increased bronchopulmonary marking, increased bronchopulmonary
Yes.
markings like curly B lines.
Yes.
Curly B lines, and there is obliteration of the right as well as left costophrenic angles.
Yes.
As well as both the lung fields are hazy.
Yes.
I think it looks like a ARDS type of picture.
Yes. So are there opacities or infiltrations?
Ma'am,
infiltration actually.
Infiltrations will be the better
infiltration,
option.
yeah, infiltrations.
Because
interstitial infiltrates.
Yes.
Actually.
Yes. Good. Thank you.
Yes, ma'am.
Started the timer, and here is your question. Right. So if you have read and understood, considering a surgical pathologist patient, kindly tell me, what do you interfere of this patient's illness after reading the stem?
Okay, this patient, this patient is having PUD from the that presents with
What
hematemesis
is the
and
definition of PUD? What is PUD?
PUD is peptic ulcer disease.
All right.
Peptic ulcer disease and hypercalcemia. This patient may be having MEN1 syndrome, which involves hyperparathyroidism and pancreatic adenoma, in this case, gastrinoma, presenting as peptic ulcer disease, most likely hypergastrinemia, giving a picture of Zollinger-Ellison syndrome.
All right. Can you please tell me what are the risk factors which are involved in peptic ulcer disease?
The risk factor involved in peptic ulcer disease include Helicobacter pylori,
Infection.
the use of Helicobacter pylori infection, ma'am. Thank you, ma'am. Non-steroidal anti-inflammatory drug usage, smoking, stress, burns, trauma. These are some of the ones that can
Alcohol, corticosteroids.
Alcohol, excess.
All right. Okay, you mentioned infection of Helicobacter pylori. Can you please tell me what kind of organism is that?
Helicobacter pylori is a microaerophilic spiral-shaped flagellated gram-negative organism.
Yes. So how or what test can you do to confirm the presence of this organism? Or this bacteria?
The test that I will use, I can do the CLO test or the rapid urease test. That's a Campylobacter-like organism test.
Yes.
Yes, ma'am. I can also do. Okay.
Yes, please continue.
Okay, other tests that I can do to confirm the presence is to take histological biopsy of the area of the region and then subject it to culture. I can also do urea breath tests to confirm the presence presence of eradication of it. Even fecal antigen test too. Yes, ma'am.
If this test turns out to be positive, then what would be the color? How would you interpret the results?
If
urea to ammonium, yes, please.
Okay, because H. pylori elaborates urease, it will convert the phenol, which is used in the CLO test, from yellow to red, ma'am.
Very good. All right. How would you confirm the eradication of Helicobacter pylori?
For confirmation of eradication, we can use the urea breath test to confirm the eradication.
What medications would you suggest, or can you advise the patient to use for the eradication of? Yes.
Okay, this patient, I will advise this patient to be placed on the triple regimen, which involves 2 antibiotics and 1 proton pump inhibitor. The antibiotics will be either I use metronidazole 500 milligram and clarithromycin 250 milligram, or I use amoxicillin 1 gram and clarithromycin 500 milligram.
Right. In this case,
with the proton pump inhibitor.
In this case, patient's biopsy report confirmed that it was peptic ulcer disease with hypercalcemia. So what does that mean? Why there is hypercalcemia? Or what does this hypercalcemia signifies?
The hypercalcemia, what it signifies is that there is possibly hyperparathyroidism from parathyroid adenoma.
All right.
Yes, ma'am.
Any other cause?
Another thing that can cause hypercalcemia in this patient is malignancy. He could be having a malignant ulcer.
All right.
The excess ingestion of calcium too can also give hypercalcemia.
All right. Can you said there could be parathyroid adenoma. So
yes, ma'am.
What is parathyroid adenoma?
A parathyroid adenoma is benign hyperplasia of the parathyroid glands.
Okay, how should that be managed?
The management of parathyroid adenoma depends on the number of but generally it's managed by depends on the presentation. If it presents with symptoms of hypercalcemia and the calcium level is more than 12 milligrams per DL, is more than 14 milligrams per DL or greater than 12 milligrams per DL, the presence of other symptoms will manage medically. I will place the patient on IV normal saline. I will try to monitor the urine output. I will also try to give the patient diuretics. And occasionally,
I'm not sure if that was the answer to my question. Or anyway, if you do not find the parathyroid gland in its normal usual place, so what are the locations to find for it?
Okay, the location to find the parathyroid, we can find it at the base of the skull. It can be found at the thymus. It can be found at the superior mediastinum. It can be found at the mandible, at the angle of the mandible. It can be found at the tracheoesophageal groove. It can be found at the retroesophageal space.
Right. All right. Okay. And what should be the treatment of parathyroid adenoma?
The treatment of parathyroid adenoma can be managed by total parathyroidectomy and auto implantation in the non-dominant hand, or I can do a subtotal parathyroidectomy, which involves removal of 3.5 of the parathyroid gland, including.
What are the types of hyperparathyroidism that you can identify?
The primary, the secondary, and the tertiary hyperparathyroidism.
Tell me about the tertiary parathyroidism.
Ma'am, sorry, I didn't get that.
Tell me about the tertiary parathyroidism. How does it occur?
Tertiary, okay. Tertiary hyperparathyroidism results from autonomous nodule. Initially, there is hypocalcemia, but when the parathyroid gland becomes autonomic, it continues to produce parathyroid hormone even after the cause of the hypocalcemia has been treated.
All right. Okay. How should the hypercalcemia be treated?
Hypercalcemia can be treated medically.
Yes.
It's usually we start with fluid, IV fluid, and I will ensure that the patient is fully rehydrated, is well hydrated, while I'll maintain a urine output of at least 100 ml per kg. I'll also ensure that I'll give the patient diuretics. I'll give the patient bisphosphonate, IV palmidronate. I will also give the patient maybe calcitonin if it's not.
All right. All right, there were certain questions about frozen sections. What is a frozen section and when it should be taken?
A frozen section is a rapid histological or microscopic assessment of a specimen. It is usually.
And that can show raised calcium levels, serum calcium, and CLO test is positive. That's good. Right.